Yeah. So this topic indeed is of extreme importance, and the basic aim remains that we should be able to prevent this deformity. Hence, we'll be able to prevent any quadriplegia or paraplegia. And with the treatment, we should be able to restore the whole bony architecture, and that will help us in eradicating the disease. As we look at the pathophysiology, the primary infected visceral lesion and comes up with hematogenous disseminations, and then infection gets lodged in bone, which is always secondary. And these basic cells, polymorph, get accumulated and later replaced by monocytes and macrophages, and there is phagocytosis of the bacilli. And there is a formation of epithelioid cells, which again fuse to form Langerhans cells, or forms a granuloma or a tubercle. So there could be a soft tubercle with a caseous necrosis, or there could be a hard tubercle without caseous necrosis. And basically, in most of the bacteria, they settle down in a paradiscal region. That is the most common area for lodgement of the bacteria, 95% of them. But there are some which do happen in central type of tuberculosis, in the body of vertebra, or on anterior, or in appendiceal variety, which is relatively rare, and you could have skip lesions. As the bacteria starts lodging down in the bone, there is a pain. Patient presents with pain in the low back, and there are associated constitutional symptoms most of the time. As the pain increases, the local signs appear of paraspinal muscle spasm and local tenderness. And as further the destruction takes place, you start having a kyphus formation as the destruction takes place. And all this process goes on at least for first 3 to 4 months. So early features that we have in this disease are the onset of the disease is quite insidious. Sometimes it could be acute. However, there is pain and localized tenderness. Constitutional symptoms are present in about 1/3 of the patients, and they present to you with muscle spasms and painful movements of the spine. However, in the late stage, what happens is that you get a kyphotic deformity of various types, and you could get a knuckle deformity, angular or rounded kyphosis, and the patient may present with swelling, collapses, or a neural deficit, and that becomes a very late stage. However, a typical radiological diagnosis is based on the old, very well described Phemister triad on X-ray picture. There is a regional osteoporosis, there is reduction and obliteration of the disc space, fuzziness of the vertebral end plates, and loss of anterior body height, later on resulting into kyphosis, and is associated with paravertebral shadows. Prevertebral soft tissue shadows, they are very well seen in cervical region, and they are the indicators. They are the indicators for the underlying lesion. At times, they could be missed. And this is what it shows, a lifting up of the trachea on anteriorly as well, and or a paravertebral shadow. So at times, rather most of the times, the radiographs may not be able to tell you accurately the diagnosis, or they may not be able to assess the lesion in certain critical areas like craniovertebral junctions, cervicodorsal junctions, the sacrum, sacroiliac joints, or in pelvis. For all these areas, the magnetic resonance imaging or the CT scans are better imaging modalities. So as we try classify this disease in clinico-radiological method, the pre-destructive lesion, which normally is about less than 3 months, will present to you clinically in a straightening of the curvature of the spine with paravertebral muscle spasm, and on bone scan one gets hyperemia. And if MR is taken at that place, it will show you a marrow edema. However, that marrow edema may be very non-specific. As early destructive changes takes place in roughly around 2 to 4 months' time, the X-rays may show you at that time a diminution of intervertebral disc space, paradiscal erosion, and a prominence of the spinous processes posteriorly, which normally is like a knuckle, which is less than 10 degrees. The magnetic resonance imaging shows you a marrow edema. There is a break of the osseous margins, and CT may show you marginal erosions with cavitation. So that becomes an early stage where the disease need to be caught. So as the disease further progresses, radiologically you have increase in vertebral body destruction and a collapse taking place, resulting into a kyphus of various degrees. A mild angular kyphus suggests about 2 to 3 vertebral involvement, which is normally about 30 degrees or less than 30 degrees. Where there is more than 3 vertebral involvement, the kyphus increases roughly about up to 60 degrees. But whenever there is a big hump, that is, the kyphus is more than 60 degrees, normally involving more than 3 to 4 vertebrae. And all this comes, these 3, 4, and 5 are classified onto a late stage. The scintigraphy could give you a very precise location, but it has a limitation that we could not be distinguished between a soft tissue or a bone involvement. A CT scan shows you an early destruction of the bone, and site and extent of bone involvement could be very well deciphered. Soft tissue evaluation could also be made, and CT-guided biopsies at that time could be carried out. However, it has a limitation that it doesn't tell you about the status of the cord. MRI becomes an excellent investigation where it tells you the presence and extent of infection, can evaluate the cord status, and is more sensitive than X-rays to pick up the lesion, is more specific than bone scan, tells you specific localization, and it is a better tissue contrast than what you get on CT with multiplanar capability. So the early features that you find on the MR scan would be an edema of the vertebral bodies, softening and break in the end plates. That is an earliest feature that you find on the MR scan. And this is what it represents the classical MR scan with a bone marrow edema and softening of the paradiscal margins. And this is what the disc space is possibly invaginating right into the softened vertebral body. And if at this stage the patient is picked up at this stage, that is what an early stage would be. And in that stage, there will be a complete resolution of the vertebrae with the drugs. The findings are, while these findings of tubercular spondylitis would be a contiguous vertebral involvement, a relative preservation of the disc space, there could be subligamentous extension of the lesion with large pre- and paravertebral abscesses, which could be very well distinguished. The early epidural involvement can be found out, and a vertebral intraosseous abscess can be diagnosed, and a septate paravertebral shadows can be seen on classical MR pictures. And this is what it shows. There's a prevertebral soft tissue shadow. There's a classical prevertebral abscess right here, body destruction, encroachment onto the spinal cord, epidural abscess in front, and a septation of the abscess that could be very well discerned on the MR pictures. The serological test, however, the use of currently available commercial serological tests to diagnose active tuberculosis often leads to misdiagnosis or mistreatment and potential harm in the public health. This has been published by WHO, and a blood test for diagnosing active tuberculosis and disease is a bad practice, and it is being abandoned. We know that the yield from the various tissues could be very, very little, and the culture positivity could be seen in only about 30 to 60% of patients, and while synovial tissue fluid, about 20%, gives you a staining, and about 30% in the regional lymph nodes could be seen. Similarly, the PCR remains a very sensitive test, is highly sensitive for DNA amplification of these bacteria. And this limitation remains that you will not be able to correlate it with the activity of the disease. So hence, an active disease with the presence of PCR positive is diagnostic. But it's very expensive, may not be easily available at all centers. And of course, we have a facility for a BACTEC culture, which could be which could reduce your time period for detecting Mycobacteria tuberculosis in about 7 to 10 days' time. So as you compare the sensitivity of various tests, the PCR remains right on the top with roughly around 74%. So far, there's not much significant in the specificity of these tests. So in endemic region, in nutshell, wherever there are endemic regions with limited resources, clinico-radiologically, it's largely based, the diagnosis is largely based clinico-radiologically. For that, you got to have a very high index of clinical suspicion is required. So any backache which is persisting for more than 3 weeks should be evaluated extremely carefully. And in early cases, that is in pre-destructive phase, the imaging modalities like bone scan, MR, or CT are indicated. And however, the final proof had to come from the growth of the mycobacteria. So what do we have in future for us? I think in future you have a need for specific diagnostic markers for Mycobacteria tuberculosis. That would be a great achievement. And a radio imaging modality which could possibly pick up this disease at a molecular level so as to abort any further complications. Thank you so much.
Thanks, Professor Kumar. I would request you to continue on the second presentation.